Hello, my name is Jesus Berdeja. I'm the Director of Myeloma Research at Sarah Cannon Research Institute in Nashville, Tennessee. And I had the honor to present on behalf of my colleagues at this year's ASH meeting in New Orleans, the clinical activity of BMS-986393, which is a GPRC5D targeted chimeric antigen receptor T-cell therapy in patients with relapsed refractory myeloma. And these were the first results from the phase 1 multicenter open label study. So just as a background, obviously CAR T cells have made a big splash in myeloma, and these are usually BCMA-directed CAR T cells, particularly autologous CAR T cells, and with amazing results and durable results. But unfortunately, most patients eventually do relapse. So new targets are extremely needed in this patient population. And GPRC5D, which is an orphan receptor that is expressed only on myeloma cells with limited expression of the tissues, has come to the forefront of therapies. And now there is a bispecific antibody. It's actually two, but one in particular that is pretty far advanced, hopefully getting FDA approval in the next year or so. So this is actually a CAR T therapy that is directed against the same target called GPRC5D. So the study is a phase 1 study with a traditional dose escalation. We started at 25 million CAR T cells, went up to 75, 150, 300, and 450. Patients had to have relapsed refractory myeloma, at least 3 prior lines of therapy, including a PI, an IMiD, and an anti-CD38 antibody. And patients were allowed to have prior BCMA therapy, which I think is important. These are the baseline characteristics. So at the time of presentation, 33 patients have been enrolled with a median age of 63. About half the patients had high-risk cytogenetics, 45% with extramedullary plasmacytomas, and 54%, more than half, had prior BCMA therapy, including 40% with prior BCMA-directed CAR T therapy. In terms of tolerance, you see that most patients had treatment-emergent AEs. On the right table here, you see that the hematologic toxicities on the top, and so most patients experienced any grade neutropenia, and most were grade 3 or 4. 40% of patients had thrombocytopenia, with 20% grade 3 or 4. The non-hematologic AEs are on the lower part of the table here, and you see that cytokine release syndrome, as expected, is the most common at 64% of the patients, but most were grade 1, 2. Only 6% of the patients had grade 3 or 4. And fatigue, pyrexia, which is just a fever, were the next most common toxicities. There was a dose-limiting toxicity of prolonged grade 4 neutropenia that was reported in 2 patients at 25 and 75 CAR Ts, but the MTD has not been exceeded, and no deaths related to the study have been reported. When we break down the cytokine release syndrome specifically, we see that CRS was seen in all dose levels, 25 to 450, although the 450 we haven't actually reported, so from 25 to 300. But you see over here on the right side that by dose level, the majority of the CRS was still grade 1, 2, and did not seem to increase with increasing cell dose. Neurotoxicity was rarely seen. Only 2 patients had traditional ICANS with no grade 3, 4, and cerebellar toxicity had not been reported at the time of cutoff. And this is important because there was a previous GPRC5D autologous CAR T cell that was presented by the Memorial Sloan Kettering group, where at their highest dose levels, they saw 2 patients with cerebellar toxicity. So we are closely monitoring this for any developing toxicities. The target we know, although GPRC5D is mostly expressed in myeloma cells or plasma cells, it can have low-level expression in highly keratinized tissues and in the tongue and salivary glands. And so dysgeusia or taste disorders, as well as skin toxicity and nail toxicity, has been seen with the bispecific antibodies. We did see these toxicities, but as you can see, there's very low level of this toxicity, and they were very transient. This is an efficacious CAR T. As you can see, the overall response all the way to the right here is 89.5%, with complete response rates of 47.4%. As you can see, every dose level had responses seen, which is actually we're quite pleased to see. When you look at patients who had prior BCMA therapy versus no prior BCMA therapy, you see that the patients who had not had prior BCMA therapy had an overall response rate of 100% with complete response rate of 50%, whereas the patients who had prior BCMA therapy had an overall response rate of 77.8% and complete response rate of 44.4%. So again, the prior BCMA patients responded quite well, but not as well as the patients who did not have prior BCMA therapy. In terms of responses over time, you see in the Swimmer's plot, sort of the responses with time will deepen with time at all dose levels. And of course, the first dose level was 25 million CAR T cells, and that has the longest follow-up to date. And follow-up is still short for most of these. We expect a lot of these responses to hopefully continue to deepen. In terms of the pharmacodynamic analyses, we saw that BMS-986393 was able to reduce soluble BCMA levels, indicating that BCMA still correlates with tumor burden, even in the non-BCMA directed therapies. We saw a consistent profile of fast expansion and multiphasic decline following IV infusion of the CAR T. There was evidence of dose-dependent increase in cellular expansion up to 150 million CAR T cells. So in summary, at all tested dose levels of BMS-986393, we saw a safety profile that was in keeping with prior autologous CAR Ts, with no new unexpected toxicities. Cytokine release syndrome was mostly grade 1-2. ICANS type neurotoxicity was infrequent, low-grade, and reversible, and there was no cerebral neurotoxicity reported across all dose levels tested. On-target off-tumor events occurred in a minority of patients and were mostly grade 1. The dose escalation is ongoing. The maximum tolerated dose has not been exceeded. And thus far, BMS-986393 has shown a durable response and promising efficacy at all tested dose levels, including MRD-negative CRs and in BCMA-exposed patients. So these data support continuing development of BMS-986393 and appears to be effective irrespective of prior BCMA-directed therapy, and expansion in Part B is underway to define the recommended phase 2 dose levels. And with that, I'd like to acknowledge the courageous patients and the supportive families who made the study possible, all the clinical study teams participating in the study. The study was supported by Bristol Myers Squibb.